Hello everyone. In this video, I'll be talking about celiac disease. So let's start by solving a question. A 25-year-old woman comes to the physician with 2 months history of progressively increasing pain in both lower extremities. The pain is localized over both shins and is worse with ambulation. She reports a 2 kg weight loss, but no fever, night sweats, chest pain, or abdominal pain. Her past medical history is unremarkable. She is currently on no medications. Family history significant for mother and sister with hypothyroidism. The patient has a 5-pack year smoking history and drinks 2 glasses of beer on weekend. She has a nutritious diet with a regular intake of vegetables, meat, whole grain foods, and dairy products. Examination shows tenderness of both shins and vitiligo over her back. Lab findings: hemoglobin is 10.9 on the lower side, hematocrit is 33, calcium is 8, normal is at 8.5 to 10.5, alkaline phosphatase is 250, which is high, phosphorus in organic serum is low, 1.9. All right. The red blood cells are hypochromic and microcytic. Basic metabolic chemistry panel is otherwise normal. Serum ferritin level is low. Plasma 25, the oxyvitamin D level is undetectable. Which of the following blood tests is likely to indicate the diagnosis? Now, this patient is young, 25 years old. She has this progressive lower extremity weakness, okay, especially over the shins. And when you see her labs, her vitamin D levels is undetectable with a low phosphorus and a low calcium, right, and an elevated alkaline phosphatase. And the red blood cells are hypochromic microcytic, so microcytic anemia, okay. In addition, she has vitiligo and tenderness of both shins. Now, vitiligo is it's a autoimmune disorder, right? So if this is an autoimmune disorder, there might be another autoimmune disorders, yeah. So this picture goes more with celiac disease, all right. Although the patient does not have any episodes of abdominal pain or weight loss, it might be the beginning. Patient has vitamin D deficiency along with hemoglobin, low hemoglobin, and history of vitiligo. Then you must look into anti-tissue transglutaminase antibody, or which is an antibody associated with celiac disease. Okay, so celiac disease, the clinical manifestations: GI symptoms, diarrhea with or without steatorrhea, weight loss, abdominal pain, flatulence, bloating. Late manifestations as ulcerative vaginitis, enteropathy associated T-cell lymphoma. The late manifestations associated with celiac disease is very high yield. Remember, ulcerative vaginitis and enteropathy associated T-cell lymphoma. It causes dermatitis herpetiformis as well, and atrophic glossitis. Dermatitis herpetiformis is as a result of IgA deposition under the skin, dermis, and that results in dermatitis, and it's treated with dapsone. Endocrine, vitamin D deficiency, secondary hyperparathyroidism because of vitamin D deficiency. Bone disorders: osteomalacia, osteoporosis in adults, and rickets in children. Hematologic iron deficiency anemia, neuropsychiatric, peripheral neuropathy, depression, anxiety. So, this patient has iron and vitamin D deficiency despite consuming a nutritious diet, suggesting a malabsorption disorder. So, you need to look into common form of malabsorptive disorders. So, you need to order for anti-transglutaminase antibodies. Okay, so let's talk about the management of celiac disease. So, you will always recommend patients to go for a gluten-free diet and education. It's very important to maintain a diary and counseling with a dietitian. Monitor lifelong adherence to a gluten-free diet and access to an advocacy group as well. Nutritional deficiencies is most common deficiencies are iron, calcium, vitamin D, folic acid, and rarely thiamine. Prevention of bone loss, increased risk of for osteopenia and osteoporosis. So at the time of diagnosis, you obtain a DEXA. If the patient has osteopenia, then you will repeat DEXA after 1 year. You will also recommend pneumococcal vaccination and for the treatment of dermatitis herpetiformis, dapsonus, in addition to gluten-free diet. So the way to remember the management is FAB-PDF, right? F here stands for fat-soluble vitamins, which includes A, D, E, and K. B stands for vitamin B, so folate and B12 as well. Pneumococcal vaccination, DEXA, and also ferrous sulfate for iron deficiency anemia. Pneumococcal vaccination is needed because celiac disease causes hyposplenism, and therefore you need to cover with pneumococcal vaccine. And most patients get better with dietary restriction of gluten. If patient presents again with recurrent symptoms, the most likely cause may be non-adherence to the diet. Okay, so you need to maintain adherence to the diet. Okay, then coming to this question, which is basically a complication associated with celiac disease. So 45-year-old man, which is actually a late complication, right? 45 years old man comes to the office with 2 months of worsening mid-abdominal pain, abdominal cramps, and black stools. He has had fatigue and weight loss. The patient has a history of chronic diarrhea since adolescence and has diagnosed with celiac disease 10 years ago. His baseline diarrhea improves when he avoids dietary gluten, but he has difficulty doing so due to frequent work-related travel. Now, the abdomen is mildly distended with mild generalized tenderness. He appears thin and pale. There's no guarding or rebound tenderness. Bowel sounds are increased. Stool positive for occult blood. Which of the following is the most likely cause of this patient's current symptoms? It's T-cell lymphoma arising from jejunum. If you remember the late complications in this graph, late manifestations, enteropathy associated with T-cell lymphoma is one of the late manifestations of celiac disease, and it's very high yield. So how does this present? So patients with untreated celiac disease are at risk for developing enteropathy associated T-cell lymphoma, an aggressive hematologic malignancy that primarily affects the proximal jejunum. Manifestations typically begin with abdominal pain and B symptoms, weight loss, fatigue, fever. Okay? So bowel obstruction, bowel perforation, GI bleed are also common in the disease process. So most patients with EATL presents late in the disease process when curative options are limited. As such, prognosis tends to be poor with median survival of only 10 months. It's a very aggressive disorder. Okay? So T-cell lymphoma arising from the jejunum is a late complication associated with celiac disease. Then moving on to malabsorption related to celiac disease. Now, celiac disease is an autoimmune disorder, right? So it is associated with multiple other disorders. So any patient who has vitiligo may have celiac disease, or may have Graves' disease, or hypothyroidism, or Hashimoto thyroiditis. So it's somehow related to that. So in this question, so 25-year-old man comes to the office for follow-up. So he's diagnosed with Graves' disease 12 months ago. During an evaluation for diarrhea, tremor, and palpitation, he received radioiodine therapy, required initiation of levothyroxine due to iatrogenic hypothyroidism. Patient reports that most of his symptoms have improved with treatment, but he still has occasional diarrhea and fatigue. Now, in addition, his serum TSH levels have remained elevated despite escalating dosage of levothyroxine. Now, this point is quite important. In addition, his serum TSH levels have remained elevated despite escalating dosage of levothyroxine. This patient has no other medical history. BP is 130/90. Thyroid is not palpable. Skin is mildly dry. Lab are as follows. TSH is very high despite increasing the dosage of levothyroxine. Stool occult is negative. Which of the following is the best next step in the management? You would check for serologies for celiac disease. because celiac disease is a malabsorption disorder, and this may cause malabsorption of levothyroxine. Okay, so levothyroxine replacement therapy for hypothyroidism. So initial dose of levothyroxine, the standard dose is 75 to 125 mg per day, microgram per day, the standard dose. However, in elderly and heart problem, 25 to 50 microgram per day. The dose is adjusted in 6 weeks until TSH is within normal range. And you need to maintain with the same and monitor TSH every 6 to 12 months. The conditions requiring a higher dose is malabsorption, celiac disease, drugs that interfere with absorption like iron and calcium, drugs that increase thyroxine metabolism like phenytoin, carbamazepine, rifampin, or otherwise the anti-epileptic drugs. Others like obesity, pregnancy, and avert proteinuria. Okay, this patient was started on appropriate therapy but continues to have an elevated TSH despite escalating levothyroxine dose. This suggests levothyroxine malabsorption. So when you recommend or counsel a patient with hypothyroidism on levothyroxine, you advise the patient to take this drug early in the morning, empty stomach, right? 30 minutes later, patient can have the breakfast, okay? But if the patient is having iron or calcium supplements, then these drugs may be taken 4 hours later, or you may ask the patient to take the supplements, the iron or calcium supplements, later in the afternoon, because these drugs can interfere with absorption of levothyroxine. Okay, so that is a very important point to be discussed with patients on levothyroxine supplements. So, celiac disease has an increased prevalence in patients with autoimmune thyroid disease and is an important cause of levothyroxine malabsorption. Initial testing with serologic studies is anti-transglutaminase IgA and anti-endomycyl IgA antibodies is indicated for this patient, followed by endoscopy if positive. Okay, now let's talk about the management of celiac disease. Now we have seen uh, antibodies, right? So you have a suspicion for gluten sensitivity, okay? Now to hypersensitivity reaction type 4, okay? You send serology blood test. The best initial would be an anti-tissue transglutaminase IgA antibody, or you may send anti-endomycia IgA antibodies. Okay, now 8% of patients with celiac disease may be IgA deficient. Okay, and in that condition, you can do this test, which is deaminated gliadin peptide, DGP IgG antibody test. Okay, DGP IgG antibody test in patients who are IgA deficient. Now, positive serology requires a small bowel biopsy for confirmation of diagnosis. So you do the biopsy, and the celiac disease affects the proximal small intestine, especially the duodenum. So you need at least 4 duodenal biopsies, and it may show increased intraepithelial lymphocytes and plasma cells, atrophic mucosa with loss of villi, enhanced epithelial apoptosis, and crypt hyperplasia. And a very important high yield point about celiac disease is that HLA is positive for DQ2 and DQ8. Lab testing CBC iron deficiency iron studies will show iron deficiency anemia. Folic acid, vitamin B12 to evaluate the level of malnutrition and malabsorption. DEXA again is an important test to do in patients who are osteopenic and may require regular follow-up. So since these patients with malabsorption are may have fat-soluble vitamin deficiencies, especially like A, D, E, and K, vitamin B12, so they may have complications related to that. So let's see that. So this patient is 27-year-old woman. She presents with minor ache and pain in her bones and muscles. And uh, um, She's physically active, states that she has a balanced diet, full-time student and is sexually active with one partner, and stressed lately, studying for final exam and occasional experience diarrhea. Okay? She takes a cyclovir for dermatologic herpes simplex virus infection, and her on examination, the patient exhibits 4/5 strength in her upper and lower extremities, diffuse tenderness over the limbs that is non-specific. And then you see that the calcium level is very low and the alkaline phosphatase is high. And which of the following is the most likely associated with this patient's condition? Okay, so the answer would be premature ovarian failure. Okay, the reason is that the occasional diarrheas, elevated alkaline phosphatase, hypocalcemia. All right, this is celiac disease, and it can result in premature ovarian failure. Okay, so osteomalacia also presents with diffuse musculoskeletal pain, tenderness, difficulty walking. And in contrast to osteoporosis, osteomalacia presents with lab abnormalities including a decreased calcium, phosphorus, and vitamin B12. All right, and um, so you need to replace the fat-soluble vitamins in patients with celiac disease, especially vitamin D. All right, and finally, this question is also a very high-yield question, which is in regards to IgA. Now, I said 7% of the patients with celiac disease are IgA deficient, and so this question basically is a celiac disease patient who was transfused, and then this patient developed dyspnea, urticaria, and hypotension. So, which of the following is condition with this patient's clinical presentation? It's celiac disease because 7% of patients with celiac disease are IgA deficient. So, when you're transfusing blood, blood has IgA antibodies in that. So, if you are giving IgA to antibodies to a patient who is IgA deficient, this can result in features like dyspnea, urticaria, and hypotension. So, uh, celiac disease is a chronic autoimmune disorder that presents as steatorrhea, gluten ingestion. Presents with weight loss and fatigue. Celiac disease associated with IgA deficiency that results in recurrent upper respiratory and GI infections. This is very important because your patients are IgA deficient, recurrent upper respiratory infections with GI infections happens a lot. So the best initial test for celiac disease is anti-tissue transglutaminase antibody and IgA antibodies. So patients who are IgA deficient will have no IgAs. Okay, so anti-TTG antibody will be negative despite having a true celiac disease. This is what is important. Okay, so therefore, despite having the disease, the TTG test antibody may be negative, and therefore in that case you may do deaminated gliadin peptide IgG antibody test. Okay, if you're suspecting IgA deficiency. All right, so this is all the high yield commonly tested questions on step 2 CK and step 3 questions. Thank you so much. Hit the like button. See you in the next video.